Hi friends, this is a prelude to our CME, which is going to happen on 12th of March about the valvular heart disease. So I thought let us review what is the anatomy of the cardiac leaflets and valves. I begin with the mitral valve, and mitral valve is, if you see, this is anterior mitral leaflet, and that's the posterior mitral leaflet. Please notice that this is the annulus. The posterior mitral leaflet actually forms a very large circumference, while the AML involves the smaller circumference, but AML is larger than the PML. In here, if you see, this is the location left atrial appendage, this is the lateral side, this is the medial side, and the anterior leaflet AML is divided into A1, A2, and A3 scallops starting from the lateral side. So are the P1 and P2 and P3 scallops of the posterior mitral leaflet starting from lateral to medial, right? So remember, from lateral to medial, A1, A2, A3, and P1, P2, P3. So once we have a patient of a mitral valve prolapse, we have to mention which leaflet is it. This is where it is important. Now in the second video, you see the anterior mitral leaflet and you see the posterior mitral leaflet. Again notice that anterior mitral leaflet is far larger than the posterior mitral leaflet, though the posterior mitral leaflet is attached to a larger portion of the mitral annulus. Taking the story further, you notice that there are two papillary muscles which are holding this entire thing. Papillary muscle, chordae, the leaflets, and the annulus forms what we call as a mitral apparatus. Now you have two papillary muscles, posterior and anterior. Anterior is anterolateral and posterior is posteromedial, and notice they supply the chordae to both the leaflets. Now there are chordae which are attached to the leaflets. They are leaflet chordae. There are chordae which are attached to the commissure. There is a small leaflet in the commissure also which can also prolapse. So these are commissural chordae, right? Then this is the anterior mitral leaflet. Now this is from the medial side. This is A1, A2 and A3 going laterally. Another cut section of the heart in a diagram, you notice this is the left atrium, this is the mitral valve, and this is the chordae which is attached to the margin of the mitral leaflet called marginal chordae, or the primary chordae which is attached to the tip of the mitral valve called the tip mitral chordae. So this is the myocardium of the ventricle, and this is the myocardium of the atrium, and this is the ventricular atrial junction. This junction is also important, which we would discuss in mitral valve prolapse. This junction becomes very important there. Now there is a fibrous tissue here which forms the fibrous annulus, and this is where the annular calcifications would tend to happen. Please notice in this AV groove, you have a coronary sinus and the circumflex artery which goes through this place, and these are important landmarks of this sulcus. Now the mitral leaf is a very complex structure. It is designed like a saddle on the horse. Now this saddle shaped mitral valve has a very special purpose. Now this is like a saddle, anteroposterior and lateral. You can see the concavity which is going like this and a concavity which is going like this. So this is important, and why after all we have this saddle on the left side? Because of the pressure gradients. Now this valve has to hold against the systemic pressure so that the blood doesn't enter into the left atrium and it does not leak. Not only the valves co-opt, now there the saddle, look at the saddle is open. Now the saddle also collapses, so the saddle also closes. Closing of the saddle produces further strength to the mitral valve so that it does not leak. That the luxury we don't have on the right side. Now a bit about the chordae. Now I already told you we have a commissural chordae, and then we have, this is the tip of my leaflets. At the tip of the leaflets you see these chordae which are attached, and these are called primary chordae, right? Then you have, this is the primary chordae which attach to the margin, or they are also called marginal chordae, attached to the tip of the valve. Then there is a clear zone in the valve. We call this as a clear zone where no structure is attached. Then this is the rough zone of the valve leaflet where the secondary chordae actually tend to attach. There is a lot of importance of these chordae once we do a mitral annular a ring shortening, and in that situation the tension of the secondary chordae are released and not the primary. Those are kind of things which we would discuss. Now then you have some basal chordae which gets attached to the base. A bit of a dissection here. You can see this I did about an hour back, and this is on the left side. You see this papillary muscle, and you see this thick chordae getting attached to the mitral valve. On the right side we have a tricuspid valve, and let's enumerate. As it's called a tricuspid, there has to be three cusps of this valve. One is the anterior or anterosuperior leaflet, second is the posterior leaflet, and third one is the septal leaflet. Anterior leaflet, septal leaflet, and posterior leaflet as you see here. And let me share with you, now if you see the anatomy, it is quite complex, and many a times even if it is called a tricuspid, you can have just two cusps. So in 20% of the patients, the third cusp or the posterior cusp is missing. So that's why it is a lot of irregularity in structure is there on the tricuspid side. It's a far thinner valve. You can have 2 to 7 cusps. The largest cusp is the anterior cusp, and the smallest and lot of variations happen in the posterior cusp. Now if you look at here, this is the tricuspid valve, that's the anterior leaflet. This is the septal leaflet, and that's the posterior leaflet. You see scallops in the posterior leaflet. Same in you see the variation. This is the septal, the anterior, the posterior leaflets of the tricuspid valve. Now during my dissection, I saw this is, look at as compared to the left side, the right-sided valve is very, very thin. The chordae are less in number and they are small. Peculiar about, and this is what is an anterior leaflet. You can see the thin, even you could see my finger across this valve. Now you have a septal chordae also, which attach from the valve directly to the septum. That does not happen on the left side. And this is the large papillary muscle. This is the anterior papillary muscle, and this anterior papillary muscle is attached to a moderator band. Now going ahead with the anatomy, now let's see other valves. Now this is on dissection from the atrial side. You can see this is the ring, and this is the right atrium, and you can see this is the anterior, the large anterior leaflet from the, and that one is the septal leaflet, and this is the annulus, as you can see. Now let's talk about the pulmonary valve. Pulmonary valve, you see there is a pulmonary valve from the right ventricle side. You can see the trabeculations here. You can see the pulmonary valve from the pulmonary artery side, and you can see the cusps, and this is a cup-shaped valve. I'm going to share that with you when I'm discussing the aortic valve, but one must remember the relationship of the valve, which is very important for the congenital heart disease problems, which we discussed in our last symposium on congenital heart disease. Now look at, these are the two annuli. This is the tricuspid annulus, this is the mitral annulus, and you notice that the aorta is wedged inside these two annuli, and this is a normal physiology. This is very important because this does not happen in a common AV canal. The common AV canal is there. In that situation, there is an unwedging of this aorta and the aortic valve. And this is the aortic valve in the Mercedes-Benz sign, and this is the pulmonary valve, which is anterior and to the left. Now the pulmonary valve is anterior and to the left. So that's important once we talk about the transposition of the great arteries. Now these are the pulmonary sinuses and a cup-shaped valve as compared to the atrioventricular valves. Now you see from the LV side, like the pulmonary valve, you see the three cusps, and you see this Mercedes-Benz sign. And if you see from the aortic side, look at the cup-shaped structure of the valve. So that's very important, because now this is adjacent to the mitral valve. This is mitral aortic curtain, and you can see the mitral aortic valve has lot of cup-shaped cusps, and they cusps have a very different morphology. Now there is thickening of the edge of the valve, and there are nodules also on the mid part of the cusp. And notice, now there is this, the cup-shaped structures are attached like this. Actually, the ventricular arterial junction is somewhere here in the middle, okay, but the cusps actually come down into the ventricles. So now that creates a bit of an issue and a problem. The issue in the sense, what we see on echocardiography is the lower border of attachment of the valves, and this is what we call as an annulus. But what surgeon sees is the annulus here, where there is the ventricular and arterial junction, and this is sinotubular junction where these cups are attached. So now there are kind of three annuli, which you can say this is the actual true anatomical annulus which the surgeon sees. This is the anatomical, the virtual one, which echocardiography people see as the closure of the valve, and this is important once you are considering a TAVR operation. Same thing shown here. Now this is the ventricular muscle, and this is the ventricular arterial junction, but the valve are actually attached in the ventricular side in the sinus of Valsalva, and the cup actually attaches here. So this junction falls in between the tip of the valve and the base of the valve. So that's how we have a virtual annular ring, and we have an actual annular ring which can be different. We certainly would discuss all that, and you can see in the dissection that's the coronary artery origin from the sinus, and these are the cup-shaped valves, and that's the virtual annulus, and the annulus, actual annulus lies somewhere here. That's important for many diseases. Look at the orientation of the mitral valve and the aortic valve. This is how they are oriented in an acute angle, and that's important because the flow in the aorta, which is kind of circular, goes around like this and does not produce any main stresses on the wall. Compare this with the bicuspid aortic valve. This is done on an MRI diffusion, and you can see the jet actually tends to create some pressure problems on this wall of the aorta. So thank you guys. I hope this anatomy would be useful to you, and we would certainly discuss how this anatomy is applicable as we go along.